time for another podcast by George. Straight talk, straight from the heartland, that'll have you saying, by George, I think he's got it. Now, here's George.
Hello, hi, how are you? Welcome on in to another podcast by George. Welcome to the worldwide headquarters of the PBG, folks, and greetings. I really appreciate people that watch this live. We're streaming today to Facebook, and I love doing that because we've got the good doctor back. He's ready to make a house call for you, really. If you have questions or comments for Dr. Andrew Nish, please join in the show, share this with other people so they can ask their questions. And here's my intro. Dr. Andrew Nish has spent, I think, over 3 decades now as an interventional radiologist. His passion is to educate the public and healthcare workers about true health and well-being and how this can be achieved through lifestyle changes, including food and nutrition, stress management, sleep, exercise, purpose in life, and social relationships. He's especially fascinated with the mind-body connection. He gives a lot of speeches and talks on that. I've seen it, folks. If you get an opportunity, go see Dr. Nish. Maybe when this COVID thing passes, go see him in person because those shows are really great. And it's all about how our thoughts and beliefs directly influence our physical and mental health. So let's see if we can bring him on in here and get this added to the stream. And there he is. Good morning and welcome, Dr. Andrew Nish.
Hey, thanks, George. It's great to be here again.
Yeah, thanks for coming on in. And, we've got some cancer news that we want to talk about. Joe Biden has announced this new initiative. We want to talk about that and some other things that are cancer related, which is what you've devoted your professional career to. But I couldn't start a PBG, a live line right now with a doctor on and not talk about COVID. So, I want to talk about that. I want to take a spin through some articles, some coverage just today. I'm going to read this for our listeners that may not have seen it, and then you can jump in anytime that you would like. So this is, oh no, that's from the cancer thing. Let me get back to over here to... Let me get the right slide up, George. Here we go. Bring this back. Bring that down. There we go. Okay. The headline out of the Des Moines Register: significant drop in new cases and hospitalizations. I mean, that sounds good. Deaths remain elevated, however, with Iowa's toll rising to 8,829. COVID-19 continued to decline across Iowa, and the State Department of Public Health's data release on Wednesday, just yesterday now, which is expected to be the last full update before the state's dashboard is taken offline and the data is transferred to the health department's main website. I mean, I don't mean to laugh, but honest to God, here we are in a pandemic. People are still dying of this. People are still getting infected. The hospitalizations are still up there. And the governor's decided we're not going to put it on the front page of the state website any longer where people can easily access it and find it. We're going to put it on the IDPH website and make it difficult for people to find, it looks to me like. But it reads on with the number of people hospitalized in Iowa with COVID-19 dropped to 617, the fewest since late November 2021. That's interesting to me because... Doc, here we are in the throes of a winter still. I mean, it's still cold out there. I know it's kind of a loose relation, but I wouldn't expect these hospitalizations and infections to be declining at all in the throes of winter. So, I mean, this might really be a good sign because of that or no?
Well, COVID has been, as we all know, markedly unpredictable.
Yeah.
And, we still need to be vigilant that COVID still exists. People are still getting sick. Those people who have been vaccinated and with their 3rd dose are significantly less ill. I mean, we've said this over and over and over. And, COVID's going to be with us probably for a long, long time. There was just an interesting article at NPR, and it looked at the COVID lineage tree. And the Omicron variant just kind of popped out of nowhere. I mean, it didn't really have the same lineage as Delta and things. So, we think we know COVID, but we don't know COVID. We don't know what's going to happen next. Yes, infections are going down, hospitalizations, and I haven't seen our numbers for this week have been going down. And again, the best protective mechanism is getting the vaccination, getting the third dose. I would, you still have to be cautious and wear your mask in public. I know states are dropping mask mandates and people are tired of mandates and it's a political hot potato. But you know what? Be sensible, take precautions, and move about and enjoy your life. But that means getting vaccinated and using a mask where appropriate, indoor spaces, multiple people that are outside of your family.
Yeah, use some good old common sense. So let me continue with this here. I want to continue to read this because some of this is interesting. Now, this is a quote in the Register. Quote, at the height of our hospitalizations in November of 2020, for 75% of hospitalizations, the primary cause was COVID. Iowa Governor Kim Reynolds said, today, the percentage of hospitalizations that are primarily due to COVID are under 50%. So we're seeing a significant decline. Okay, Doc, I'm reading that and I'm thinking, wait a minute, you're telling me that this is good news, but you're also at the same time telling me that about 50% of the people that are in hospitals in Iowa right now are there because of COVID. I don't, that's not necessarily good news.
You know what? I don't think those statistics are correct. At no time in our health system were 75% of the people in the hospital had COVID. That just isn't correct. When we look at the height of COVID, we had about 160 people between our three hospitals, which is Methodist Downtown, Methodist West, and Lutheran, and that's about 600 and some beds, close to 700. So if we had 160, at the height, maybe 20 to 25% of the people in the hospital had COVID. But here's the real thing. And this is the statistics we don't differentiate. How many people actually came into the hospital because of COVID symptoms and having COVID versus how many people are in the hospital for another reason and tested positive for COVID? So those are differentiators we don't know the answer to. So somebody comes in with a heart attack, they're going to get a COVID test. They might test positive. So is that a COVID case or is that an incidental case of COVID in someone with another disease? So we didn't even approach 75%. That's just complete nonsense.
Yeah, okay. Well, that's from the governors I mentioned. So that's not from a healthcare practitioner. Right. That's not from a statistical resource. That's maybe just off the fly. I don't know exactly what that is, but like the doc says, that's not right. Okay. Another drop was also recorded in the number of COVID-19 patients requiring intensive care, though not by as much as previous weeks, interestingly, down to 96 from 109. Patients requiring ventilators declined to 42. I'm going to say maybe those stats are due to the fact that Omicron is less severe and maybe people aren't needing intensive care and ventilators like they were with the prior variant Delta. New reported cases also declined this week. There were 12,833 over the previous 7 days, or about 1,833 per day. Man, that's a lot. But it's a drop of 44% from the week before, and the fewest of any week in 2022. So again, I'm just hoping that we're not out of the forest, folks, but maybe we can see the outlet at this point. That number comes with a caveat. It most likely doesn't capture all the new cases in Iowa. Now, here's why. People may be less likely to report asymptomatic cases and those confirmed by at-home tests to the health department. The latter, especially now that free test kits are being made available by mail through the federal government. The COVID-19 vaccines, also available for free, rolled out across Iowa to pace similar to previous weeks. IDPH reported 57.4% of all Iowans are now fully vaccinated against the disease, and more than 51% of those have also received a booster dose, which provides particular protection against the dominant Omicron variant. Okay, so I just kind of ran through that. But when I read that, Doc, I had to stop for a second and think for what they're saying here. So 57.4% of all Iowans are now fully vaccinated. I'm thinking like they've gotten 2 doses against the disease, and more than 51%, or roughly half of those people that have gotten the 2 doses have gotten the booster. So it sounded like good news. And I thought, well, probably you would like to see more people get vaccinated, obviously, but also get that booster.
Yeah. So when you do that math, that means only about 27% of people have had 3 doses of the vaccine.
Yeah.
And that's just inadequate. So of course, we'd like to see more people get their first 2 doses and then also get the booster dose or the third dose. So yeah, I mean, there's a lot of people who aren't appropriately vaccinated.
Let me keep going here with this. We'll get through this article very quickly, but it's very interesting, and I love having the doc on here to comment. New reported COVID-19 deaths. Now, this is interesting because this doesn't look very good, but it says they typically follow several weeks behind the trends of new cases and hospitalizations. They remained elevated. There were 172 additional COVID-19 deaths reported this week, some occurring as far back as October of 2021. Now, that brings Iowa's COVID-19 death toll to 8,829. 1,000 of those have been reported from Polk County, making it the first county in the state to reach that total. There's a couple of different ways of looking at that, Doc. Polk County, the most populous county in the state. So I guess that stands to reason. And you could look at this and say, well, you know, compared to other states and the entire country, these numbers aren't as bad. But you must, it must really make you sad to look at statistics like this, because a lot of this is completely unnecessary because of the available vaccinations and boosters and so on.
Yeah. I mean, I don't know what else to say, except, you know, if people would get their vaccination and get their third dose, they'd be highly protected from hospitalization. There was just a statistic released by the CDC last week or the week before, and it showed that people who were fully vaccinated with their third dose were 60 times less likely to die.
Wow.
I mean, you know, that kind of says it.
That pretty much says it all, yeah.
But you know, the other thing, George, is, you know, we have all these, and there's been very widely varying estimates of this, but, you know, we have reported cases. Well, how many unreported cases are there? I get a home test, I do the swab, I'm positive. Well, I'm probably not reporting that to the public health department. So, you know, it varies widely that we may have anywhere from 2 to 5 times as many cases that have never been reported. So I think when we really need to focus more on not number of cases right now, but cases that are resulting in severe illness, because there's lots of cases, I'm sure, that are going unreported.
Well, I've got some friends and family members I know that tested positive with the at-home kits and treated it at home and did not report it. So, I mean, that's undoubtedly a fact. Well, I want to read this to kind of wrap up, get close here to the end of this, because I thought this was very interesting and very revealing and really a commentary, not only on Iowa, but the country as a whole. It says changes are coming to states' COVID-19 data reporting. Now, that update from yesterday here in Iowa is the last expected weekly data release on the state's public dashboard at coronavirus.iowa.gov. Once Reynolds' COVID-19 disaster declaration expires on February 15th, the website will be decommissioned and COVID-19 data tracking will be transferred to the main IDPH website. Okay, I mentioned that earlier. Now, here's another quote. It's been in place for 688 days, almost 2 years, Reynolds said of the disaster declaration. We need to move on. I think Iowans know what they need to do, and they've demonstrated that. And so it's time to end it and move on. And we need to treat it like we do other viruses. Okay, Doc, I wanted you to comment on this one because I got to ask you, this move on thing and citing the fact that it's been over 2 years. I hear people talk about this. I mean, when it comes to a pandemic and a deadly virus like that, I can't for the life of me understand why that makes any difference. And then the second question that for you is, should we treat this like we do other viruses? What does that mean? Do you have any idea?
Well, you know, that's the same verbiage we've heard now for months and months and months, right? Iowans will do the right thing, and Iowans know how to protect themselves and all of that. You know, I think at some point, George, we do as a society have to kind of move forward with life. But that also involves, you know, some minor sacrifices, at least at this point, and that continues to be mask wearing and vaccination. So, you know, I still think that we ought to be tracking these numbers. I still think we ought to have robust data to understand what's happening in our community and our society. So I would disagree with just, you know, kind of eliminating this whole COVID data analysis. And, you know, it's sort of interesting where you are. was out in Idaho a few weeks ago, and before I went, I asked my son, I said, how's COVID out there? And he kind of looks at me quizzically like, what do you mean, Dad? We don't have COVID here. Yeah. So it's the same attitude. It's we don't want to believe it's here. But we've got to get to a point where we live with this virus. We accept that this virus is going to kill tens of thousands of people every year, just like the flu does. Okay, the flu kills estimated 30 to 40,000 people. That's probably going to happen with COVID. But we are going to have to learn as a society how to live with this, how to be with this, and what are the best actions to take. And time will tell.
Let me wrap it up here with this little summary on statistics. Goes right in line with what the doc is talking about. The latest COVID-19 numbers in Iowa, the latest data this Wednesday compared to just a week prior. Confirmed cases, 735,422, an increase of 12,833. And again, that surprises me because exactly what he's talking about, the situation in Iowa. But there's a lot of people here in Iowa that'll tell you it's over. I mean, it's not of concern. But my God, the confirmed cases are up that much. Deaths, 8,829, an increase of 172, probably delayed reporting there. Total tested, 2,427,275. So there's enough concern out there that there's a lot of people getting tested anyway. Totally recovered, 616,291. Now, I got to wonder about that a little bit because these long hauler COVID symptoms, they seem to come and go. I would hope that that many people are totally recovered. And the statewide 14-day positivity rate, 15.9% currently. So, Doc, anything you'd like to comment on there? And I would like to ask you just where we're at today. And like I said, hoping that maybe this is starting to wane. What's your overall assessment? I mean, I can sense your disappointment with how this has been handled. Were you surprised at the way that this has gone? And are you surprised at where we are today?
Oh, that's a hard question because I don't know. It's interesting looking at that 14-day positivity rate. Do you remember when this first started and we were going to shut the schools down if there was a 15% positivity rate?
Yes.
And, that sort of all went by the wayside. I just feel bad, George, that so many hundreds of thousands of people have lost their lives when we did have a remarkable development of 2 very effective vaccines that could have saved tens, if not hundreds of thousands of lives. And I just wish that we had the political wherewithal to skip the rhetoric, skip the animosity between blue and red, and just do what was shown scientifically to be of benefit to the population.
I couldn't agree more. And there was plenty of credit to be passed around. People, as much as the people that I know particularly dislike Donald Trump. I mean, it was his warp speed program under which the vaccines were developed. So, I mean, you could give him some credit. You could give the Democrats some credit. You could handle the political sphere. Everybody could get vaccinated. You could make it a patriotic call to duty. I'm always reminded. I just saw a little bit of the Saving Private Ryan movie recently. My God, that invasion in Normandy, they dropped the gates on those landing craft and those guys ran out of there and I mean, every single one of them killed by machine gun fire. I mean, we were able to do that for the public good. I mean, they were just simply told that they had to do that and that it was going to save their country and save their friends and relatives. They were able to do that. And we were so reluctant.
George, before you get too wound up, let's move on to the next topic.
Yeah, I'm with you, pal.
I'm trying to save you here.
Yeah. Well, I mean, yeah, that's all right. I mean, yeah. So let me, before I digress too much, let me bring this back in here. All right. So this is something, again, because of Dr. Nish being an interventional radiologist, spending over 3 decades working in this cancer field. This is big news, and it's kind of old news in a certain respect. It's this Moonshot program that Joe Biden is talking about. It's something that Obama had also, that they kind of started and it kind of fell by the wayside. but it reads, can Biden's moonshot cut cancer deaths in half in 25 years? He says that's doable. And so just to read this here and then we'll get to the doc. Washington, Dateline. President Joe Biden set a national goal Wednesday of cutting the number of cancer deaths in half over the next 25 years as part of a government initiative that will focus on improving cancer treatment and prevention. Biden, who has made ending cancer as we know it a priority for his administration, vowed to supercharge the Cancer Moonshot initiative that he led during his final year as vice president under Barack Obama. We can do this. We can end cancer as we know it, Biden said in his announcement at the White House on Wednesday. This can really be an American moment, the president said, in which the U.S. proves to the world that we can really do big things. And that's where the moonshot of it comes from. And as the doc knows all too well, some 600,000 Americans die of cancer every year. But the Biden administration believes that progress in therapeutics, diagnostics, and other scientific advances in the 5 years since the Obama Moonshot Initiative have made it possible to set even more ambitious goals. The goal is to cut the cancer death rate in half in the next 25 years, Biden said. It's bold, it's ambitious, but it's completely doable. Man, I'm just like, I'm on the bandwagon. I'm cheering. And then I read this and I highlighted it. The new initiative includes the creation of a White House cancer cabinet and mobilizes multiple government departments and agencies to set goals for improving cancer detection and prevention. And I thought, oh man, I don't know. That's sounding kind of weak, but the cancer detection and prevention is really where it's at. And that's really what you're all about, Doc.
Yeah. Yeah. I want people to understand, we hear these headlines, the American Cancer Society, we hear these headlines, cancer death rates are decreasing. And that's very true. But most of it's been driven by lung cancer death or tobacco-related death rates. So at the height of smoking, we had about 47% of the population smoking. It's now 14%. So most of this decrease in death rates has been driven by tobacco-related cancers because we have fewer smokers. Year over year, we still have more people dying from cancer. So this year, 609,000 people, or last 2021, 609,000 people will die of cancer. That continues to tick up year after year. So, this whole moonshot thing, being a skeptic, I wonder how much this is driven by the pharmaceutical industry because they have a lot to make on this. But, I like the last line, detection and prevention, and I like the last little word the best, prevention. I don't know if people realize this, but we believe, based on the World Cancer Research Fund, that 60 to 65% of cancers are preventable. Well, there's no medicines that are going to do that. And there's no pills or vaccines that are going to do that. So we really have to focus on the prevention aspect. And when you look at the budgets, the National Cancer Institute, the National Institutes of Health, preventative budgets are less than 2% of the total budget for those groups. So we really, really have to talk a lot more about prevention. If we're really going to cut death rates in half, we've got to talk about prevention because, we can continue to develop therapies, but very few of those therapies are frankly curative. People are taking these drugs for year after year after year. And at some point, most of them end up dying from their cancer. The real key to cancer is early detection. So screening is important. That's not a prevention measure. That's an early detection measure. So screening with mammography, colonoscopy, CT for lung cancer is very appropriate. And we continue to refine our guidelines for that. There's something out there called liquid biopsy where we'll be able to detect what's called cell-free DNA from tumors and detect tumors even earlier. That is in the stage right now where we're using it some for prognostication for patients with cancer. We're using it to follow some cancers. It's not really out there yet as a screening tool because we really have to learn how to use it. Okay, if I detect cancer cells, well, what does that mean in the context of actually detecting a cancer? Because the way we detect cancers now is through imaging, CT scans, mammograms, things like that. So we have to understand that relationship, and there's research into that. So early detection is key, but prevention is key as well. I think you have another graphic there, George, from USA Today.
Yes, let me
because we can kind of go point by point. I
yeah,
think it's
bring
really
this back
useful.
up now. I want to read, I'll read through this very quickly, and then I'll, Biden and First Lady Jill Biden also called for improved access to cancer screenings and early detection. Regular cancer screenings can catch the disease early when treatment is more effective, yet Americans have missed more than 9.5 million cancer screenings as a result of the COVID-19 pandemic. That didn't occur to me, but yeah, there's a lot of people that aren't getting seen as often as they would.
And what class of citizen missed most of their screenings?
Yes. Let me see if I can bring this up.
Lower income.
All right. Now this is going to be very, this is small. You got to strain the eyes to see this, I guess, but this is the income inequality graph that the doc was alluding to here. And it talks about the various countries and the inequality gap. And I've underlined who's worse at the top there, and then who's the better down there. And
yeah,
it doesn't include us.
Let me explain this graph, because this was a paper written in 2015, and it really highlights the relationship between economic inequity and health and social problems. So if you look at a country like Japan, they have very little economic inequality. And that is defined as the income gap between the highest income and the lowest income people. And I think it's the lowest 20% and the highest 10%. I think those are the parameters that they use. So as that gap widens, what you see is that the health and social problems of the countries increase. And it really follows almost a linear line, with one exception, the United States. So you can see Japan has little social or little economic inequity, and they have better health, and they have fewer social problems. Japanese live the longest in the world. Okay, their life expectancy is 4 years greater than ours. And as we move up that graph, you can see Sweden, Norway, Finland, the Scandinavian countries. We all know that they have a socialist type bent, that they provide for their citizens. They provide healthcare for their citizens. They provide social services for their citizens. They provide food. They provide shelter. And they provide basic human needs for life. And then we move along the graph, and you can see most of the other European countries are there, including Canada, which is not European, but most of the European countries and Canada. And then we move along and we see the UK, and the UK is a lot like us in many respects, and Portugal. But then we're not even close to the line. We're not even close to economic inequity of other countries. And we're way up here in the upper right-hand corner. Of the developed countries, and these include all of these countries, we are the highest in economic disparity, and we are the worst as far as an index of health and social problems. I mean, this is an utter embarrassment. Yes. We spend more money than any other country in the world on healthcare, yet we're not even close to being the healthiest. So there's another statistic, and this isn't just cancer, but this is another statistic. So in 1980, on average, we spent just a little bit more on healthcare than most of these other countries. And at that point, if you looked at the average death rate, we were actually better than most of these countries in that we had 88,000 fewer deaths than would be predicted by the average of these other countries. That was 1980. Fast forward now to 2017. We spend at least twice as much money per person on healthcare as the next country. And guess what? In those 37 years, we now have not better life expectancy, but we actually have, if you predicted it based on the average life expectancy of all these countries, we have an extra 488,000 deaths.
Jeez.
So we have an extra 1,300 people dying per day in our healthcare system compared with the average of these other countries. So when you take 1,300 and you multiply it by 365, that's where you get almost 500,000 people. And so every day, extra 1,300 people are dying, and nobody talks about it. These are excess deaths that can be prevented if we had better social equity, economic equity, and we had a better healthcare system.
Oh man, you're singing my song. I mean,
so it's abysmal.
Yeah,
it's abysmal. And yet most people would consider the United States to have the best healthcare system in the world. We don't.
Well, we have the wealthiest, we have the most that have the most among us, and we have the least that have the least among us. And that's that inequality, that gap that the doc is talking about. And those countries that you saw on that line, as you move up, and including the UK, then you're moving into predator capitalism. And the way that you stay wealthy is not necessarily by acquiring more, it's by keeping others down. Jeff Epstein talks about that all the time.
We can talk about this moonshot. And I'm guessing a lot of this moonshot is going to go to developing new therapies.
Yes.
But if you really want to change the trajectory of health, and you really want to change the trajectory of cancer deaths, then you have to change the trajectory of what we're doing as a society.
Yeah.
And that means we have to make a conscious societal effort to redistribute income. And I know that's heresy in this capitalistic world, but we have to take better care of our disadvantaged socially and economically brother and sister.
That's right, Doc.
Or we are not going to move this needle one iota. Number one, those people who are socially economically disadvantaged have no access to healthy food. They're afraid to go out and move because of the neighborhoods they live in. They're under constant stress and anxiety. How am I going to pay for rent? How am I going to pay for food? Is my life in danger because of the people shooting guns down the street? Unless we change those things, we don't have a prayer that this moonshot's going to work. So it's a societal issue. It's gun violence. It's obesity. It's domestic violence. It's kids growing up without parents. It's kids growing up without any means whatsoever. I mean, when kids are going to school and their only meal of the day is the lunch at school, we have a real problem.
Yeah.
And it's to me a national embarrassment. It's a political embarrassment. We have politicians that all they're worried about is the next election cycle and sucking up to Donald Trump or whoever. Nobody wants to address the hard issue. And the moonshot, is great to at least put cancer in a forefront, but it's not the answer to these problems. Let's talk about a moonshot of societal equity with appropriate housing, appropriate neighborhoods, appropriate food available to everyone and anyone. And then we can change the trajectory of disease.
Then we can have a moonshot for cancer.
Okay, we have a moonshot for everything. Because risk factors for cancer are the exact same risk factors as cardiovascular disease, autoimmune disease, dementia, and neurologic diseases. They're all the same risk factors.
Well, I'm going to read through this now very quickly. We just got a couple of more slides, and then we're going to get to something else that I know that the doc wants to talk about. The administration's renewed push includes at-home screenings, especially for colon cancer and the HPV virus that causes cervical, neck, and other cancers, as well as mobile screenings in communities without easy access to a clinic. I wanted to ask you about one thing there, Doc. My understanding is that the at-home colon cancer screenings weren't good, or they're not covered by insurance. There's something about those that's kind of a negative. You know what I'm talking about?
Well, my adage is, George, the breast screening test is the one you're willing to do. Oh. Okay, so it's better than no screening. You can look at the negatives, but there's a lot of positives. Number one, I can ship it to someone's home and they can do it at home. They don't have to travel to an institution. They don't have to prep their bowels and all of that. So if I ship the fecal immunochemistry test or the Cologuard test, which tests for both the presence of blood as well as abnormal cellular DNA, at least I'm getting that to a person to take that test. If it's positive, then that person has to go on to the next test, which is colonoscopy. So the best screening test is the screening test that people are willing to do. And, you know, it's much easier to distribute those screening tests into disadvantaged populations than getting those populations into a hospital or a lab to have a colonoscopy. The problem is, you know, you can send people the test. Are they going to use the test? You know, that's the other whole issue. There's a lot of, particularly in the lung cancer screening, people don't want to know. You know, they don't want to quit smoking cigarettes. They're scared. They're worried what the future is going to hold. And so they just don't get screening. So we really have to do a much better job at public messaging. And I think there's a lot of, particularly in the lung cancer screening, there's a lot of shaming that goes on. You know, people know there's not a person in the world who doesn't know smoking is bad for you. And the worst thing we can do as healthcare practitioners is shame that person. And because that leads to resistance and resentment, and I'm not going to do what you tell me. So we have to be empathetic with those people. We have to understand that, you know, this is not a moral failure on your part. This is just, you started smoking, you got hooked on cigarettes. Let's talk constructively how we can help you get off of those. So there's just a lot of shaming that goes on in society, and that's true with obesity as well. We shame obese people. And you know what? It's not a moral problem. It's not a glutton sloth problem. It's a hormone problem, and it's based on our food system that's been co-opted by big food. So we have to do a better job at public health messaging. We have to do a better job at getting these tests to people. So, you know, getting screening tests to people as opposed to having people come to our institution is a great idea. Practically, it's very, very difficult to implement.
It's messaging is all important, and it reminds me of what I'm reading here, because some of this messaging isn't that great. The White House also will host a cancer moonshot summit to bring together biopharmaceutical companies, patient organizations, research institutions, and healthcare communities to highlight innovations and progress toward improving cancer treatment and prevention. A date for that summit has not been announced. So, I mean, some of this is really early. And now we're getting to the screen that's going to take us to the next jumping off point where I wanted to go with the doc. I would just say in summary here, Joe Biden campaigned on a public option that he was going to get adopted during his term as presidency. That's not happening. Medicare for all isn't even on the table. And people hear me talk about that on my podcast all the time. We won't talk about it today, but it's one thing to have access to healthcare. It's another to be able to afford it. And it's another thing to encourage people to go get it with some real programs and policies that'll make that happen. Well, here this reads on that says 3.5 million cancer deaths prevented in recent decades, but disparities are alarming. That's what the doc was talking about. And then 50 years after the U.S. declared war against cancer, the fight continues. These are the 10 biggest victories. So this is the Big 10. I'm going to bring this. So
let's just back up 1 minute.
Yeah.
50 years we declared a war on cancer.
Yeah.
Yet we have more cancer deaths per year than we've ever had in our history. So
right.
Cancer, you know, cancer is not heart disease. Okay. It's not throw a stent in, give you some meds, and off you go. Cancer is a disease that is constantly changing, constantly mutating. And, you know, it's not a one pill fits all cancers. And so we have to recognize that it's a highly complex disease. And there is a distinct interplay between our genetics, our environment, and believe it or not, George, how we view ourselves in this world and life.
Sure.
So it's just an enormous, you know, we've taken this very reductionist biomechanical view of health and cancer. I mean, there's nothing that drills down more to the reductionist view than cancer, right? It's all about a molecule. It's all about a receptor on a cell. But we have to look at it and focus more holistically on this and not just be giving people chemotherapy and immune therapy and some of these therapies that we've developed, but it's really about taking care of that whole person. How do we take care of their nutrition? How do we take care of their mental health? How do we take care of their financial health and all of these other things?
Well, and we started off talking about the doc's over 3 decades now as an interventional radiologist. So he's seen a lot of this come to the forefront in the treatment, detection, and prevention of cancer. That they've put together this top 10 list of, I don't know, victories or positives anyway. And I'm going to just run through these very quickly and get the doc's perspective on this because he's lived it, man. So let's
talk about imaging.
Yeah.
That's the world I lived in. all my life. And we've made remarkable progress in what we can detect, what we can see. So, before we had CT scans, and remember, CT scans are an invention of the late 70s. We didn't have CT scanning before then. We didn't have ultrasounds before then. So, tumors were detected much later. You had to feel it, okay? And then by the time you could feel it, well, it's pretty large and it's probably grown and outside the organ of origin, and you were a goner. So imaging has made a distinct difference at early detection. So we'll give that one a plus for sure.
Okay, good. And that includes PET scans, which I hear a lot about. Now, that's a recently new innovation, isn't it, Doc?
Yeah, PET scans have been around for, let me think about that. I didn't train with PET scans, so I trained over 30 years ago. So PET scans probably around 20, 25 years.
Oh, okay. All right, good. Well, that's number one on the hit parade, imaging, the doc's world. Number
Survivorship.
2. Yeah.
So this is an interesting point. We have more cancer survivors than we've ever had. So this is true. We are keeping people alive longer. No question about it. But again, more people are dying every year, year over year. So survivorship is really important because we're giving these highly toxic therapies, whether it's radiation therapy, chemotherapy, and all of those can have downstream consequences. So for example, if I irradiate a breast tumor in a woman, particularly if it's a left-sided breast tumor, she may have an increased risk for coronary artery disease down the road because that radiation has caused some damage to her coronary arteries. Now, we have newer technologies to try and minimize that effect. Chemotherapy, we know that chemotherapy can lead to downstream cancers. So it's really important in survivorship that we're not only taking care of these people from a physical, emotional, mind-body aspect, but that we're also recognizing that they're at increased risk for specific diseases and alerting them to that fact. So survivorship is really, really important. And the American College of Surgeons, the Commission on Cancer, has made that a real priority in making sure people are enrolled in survivorship programs over the last decade.
Here's the next one. And this, I don't know. I don't know how they numbered these, but I mean, this could have been number 1, obviously, prevention.
Yeah. So this is, when you look at what's been the biggest driver of decreases in cancer deaths, as we talked about, it's tobacco-related cancers. And that had nothing to do with drugs we've developed for lung cancer, but it had everything to do with public health initiatives. So what did we do with tobacco? We put it behind the counter. You got to go up to the lady at the service counter to buy cigarettes, and she's going to ask for your ID, whatever. We taxed it, okay? States that have imposed huge taxes on cigarettes have less teen smoking. We vilified it. We've hammered home the message that tobacco smoking is deadly. We've taken away all advertisement, right? We don't advertise cigarettes. Right. And those public health initiatives have decreased the smoking rate from a high of almost 47% down to 14%. So that had nothing to do with development of new pharmaceuticals and everything to do with public health. And so we need to look at the same thing. Okay, what's smoking used to be the number 1 risk factor for cancer. It's now probably metabolic dysregulation and obesity. So if that's a leading cause of many cancers, what can we do about it? Well, we've got to hold the food industry accountable. Sugar taxes. Sugar taxes have been shown to be effective at decreasing the amount of sugar consumption, and sugar consumption is absolutely one thing that drives cancer. So we need to look at public health initiatives for improving our food system. And that means informing people in a truthful manner about what the food system is doing to them, and then also getting government support to begin to support the production of of nutritious food. And nutritious food is not wholesale row crops of soybeans, corn, wheat. Nutritional food is things like kale and broccoli and cauliflower and beautiful vegetables and fruits. So it's going to take a massive undertaking of government intervention, local intervention, taxes, different subsidies, and I frankly don't see the will for that at all.
Yet there is a very effective precedent, and that is tobacco, as the doc mentioned. If we had the desire, it could be done. Screening, Doc.
So screening, we've talked about screening a bit, and screening is not a primary prevention, it's early detection. So we know in the cancer world, the smaller the tumor, the more likely we are to cure that cancer. So we have mammography. And if you look at mammography, that's probably decreased death rates by over 40% over the last several decades. Colonoscopy, there's no question colonoscopy saves lives. When we detect a colon cancer early, it's much more likely we cure that colon cancer. Lung cancer, the same way. With lung cancer screening, if we can shift from late stage cancers, which means they've metastasized or gone to lymph nodes or other parts of the body, and we can shift that detection to early stage cancers where we can remove them surgically or radiate them, we can improve life expectancy and cure rates. So screening is a big part of improving cancer outcomes. No question about it.
And they also mentioned these liquid biopsies that you talked about earlier.
Yeah, again, those are, those are not ready for prime time yet. They're going to be coming. We have to really understand when we detect cancer, cell-free cancer DNA, what do we do with that? Because, it's been postulated, and I think quite accurately, we are all probably developing small cancers all the time, but our immune surveillance system is taking care of them and we never know. So if we find a little piece of cell-free DNA, what does that really mean? And so that's going to take research over the next several years to really understand how to use liquid biopsies in the settings of screening.
This is great. I mean, this stuff is right in the doc's wheelhouse. We're lucky to have him on here to comment on these things. Genetics.
So yeah, we're enamored with the genome because we can analyze it, we can study it, we can slice it, we can dice it, we can change it. But I want people to understand that only 5 to 10% of cancers are due to genetic mutations that are passed on from generation to generation.
Wow. Yeah.
So the vast majority of cancers are environmental influences on our genome. Go back to that slide for a second.
Yeah,
George,
sure. Let me see if I can bring that
because
up.
I want to comment on something in there. So cancer research discovered in the 70s that cancer is basically a disease of genetics. I'm going to disagree with that statement, and that's a bit of heresy. We think it's a disease of genetics, but there are other postulates about what drives cancer. And one of those postulates is that cancer is a metabolic disease. Cancer is driven by dysregulation of our metabolic system, which then drives changes in the genetics of the cell. So, we think, and we've said, oh, it's a disease of genetic changes in the cell. That may be the downstream effect, but what's the proximate cause of cancer? It might be more of a metabolically driven disease than we've realized. So there's many researchers out there looking at the metabolic effects on cells and driving cancer. So I would say that's still open for debate, is what's the proximate cause of cancer? Is it really genetics, or is it metabolic dysregulation of the cell that then leads to genetic changes?
I'm just a dummy that looks at these things, right? I look at that, doc, and I think, okay, genetics. One thing, if you're looking at your parents as an example or family members, and you're looking at that as a genetic cause, you're oftentimes sharing the same socioeconomic environment.
Exactly.
Yeah, I mean.
So most cancers, there are definite what we call germline mutations, the BRCA mutation. If you have a BRCA mutation, whether it's 1 or 2, and you pass that on to your family, and there's a 50-50 chance that'll happen, then you have a definite increased risk of cancer based on that mutation. Now, there are other what we call polymorphisms. Those are genetic changes in people that may predispose them to a cancer in the right environmental circumstances. And so, there are people who may have genetic changes not passed on generation to generation that may increase their risk, let's say for lung cancer, if exposed to cigarette smoke. Or there may be people with genetic changes who have an increased risk of cancer if exposed to obesity and metabolic dysregulation. So it really is an interplay between our environmental factors and genetic factors. But you have to understand, why have we seen more and more cancer year after year? Our genes don't change that fast. It's the way those genes are expressed because of our overlying environment. And genetic expression is dependent on so many things. It's dependent on what we eat. It's dependent on how we sleep. It's dependent on how we move. It's dependent on how we interact in society with relationships, with stress and anxiety. All these things drive whether genes are turned on or turned off.
Personalized targeted therapy. I read that and I thought, well, what exactly does that mean? But I got a feeling it's important.
It is important. You know, it used to be 20, 30 years ago, oh, you had colon cancer. Colon cancer was colon cancer. You all got the same treatment. Some of you did well, most of you didn't. Now we're able to look at molecular markers on the cell membrane of cancer cells, and we have drugs to target those. So it really is quite remarkable, what we've developed to target specific therapies to specific markers on cells so that we can improve outcomes. Now that comes with a cost. So for example, a lot of these drugs cost anywhere from $90,000 to $120,000 a year. There's some therapies which are more of, genetic manipulation of tumors. One called CAR T therapy, $400,000. So this stuff is incredibly expensive. Yeah. Our bang for our buck, our return on investment, everybody's concerned about return on investment, is prevention.
There you go.
But yes, we can now we can more personalize care based on more precise analysis of markers of tumors so that we can match the right tumor with the right drug.
Moving on to number 7 on our Big 10 hit parade here. Now, this is something that I would assume that you have personally witnessed over the last 3 decades, these combination of treatments.
Yeah, I mean, cancer is a tricky disease. So, if we can cut it out, we try and remove most of the cancer in cases so that we get the main tumor out. We then radiate tumors, we then give chemotherapy. But when you look at chemotherapy regimes, it's usually not a single agent. It's usually multiple agent, because cancer cells can mutate quite rapidly. They can change their profile such that they evade certain therapies. So by combining different points of action, we may target the nuclear DNA in the cell. We may target, the endoplasmic reticulum. We may target other things in the cell, but we have this multi-pronged approach to most cancers because they are slippery, they do mutate, and so we want to try and get them at different points in their life cycle.
Number 8, we talked about this quite a bit already, but I mean, this is a huge one. Again, I wonder about the hierarchy, the order of these points, but number 8 is cost consideration.
Yeah, so out-of-pocket costs continue to increase year after year for cancer patients. Cancer treatment has become more and more expensive, and we now talk about not only chemotherapy toxicity, but financial toxicity. Many patients, there's been this famous paper that, people couldn't afford a $400 emergency. Well, out-of-pocket costs for cancer patients on average now average about $4,000 a year, I think. Yes. Yeah. So there's a significant financial toxicity, and we really have to begin to be very open and upfront with people about their care. And one of those discussions is, what's this going to cost me, doc? So you have an 80-year-old patient who has let's just call it a treatable but incurable cancer. Yes, we can give you chemotherapy, and yes, we can extend your life expectancy for 12 to 18 months. But I think the next important question is, at what cost? And people have to factor that into their decision-making. Like it or not, we cannot make decisions outside, without including cost in that. Because, you could treat someone and they might live an extra year and a half, but all of a sudden they're bankrupt and they have nowhere to live. So this is an enormous issue, and we can't just continue to increase cost of care. It's unsustainable.
I'm just a rube looking at the inside of this. I read this thing every day in the paper, famous people's birthdays, and these people live for a long time. I look at these Hollywood stars and rock and roll people, even the Queen of England I saw on TV last week, and I God, man, she's 96 or something like that. How do those people live so long? Well, these cost considerations, this slide that we had up earlier, it's not in play for those people. I mean, they don't have to make decisions like that. I mean, They're getting it. They're getting the best that there is. And it seems to be extending their life. To me, that's kind of proof positive of what we're talking about. Let me bring this next one up here now. Immune warriors. I'm going to let you talk about this one because I don't know what this means, really.
Yeah, this is a really exciting development that's happened over the last, 5 to 7 years. And so we've always known that our immune system is important at keeping cancer growth in check. But now we're able to use drugs to harness our immune system, because one thing cancer cells do is they cloak themselves. They mask themselves from our immune system. They become invisible. So these drugs, in a very simple term, make cancer cells visible to our immune system, so our immune system can then begin to attack those cancer cells. A very exciting part of cancer therapy nowadays, and we're developing more and more what we call immune therapy. So this is a really exciting frontier. The other exciting frontier is our gut microbiome. So we have these, 100 trillion bacteria, viruses, fungi that live in our gut. And we're learning that they are incredibly important in cancer treatment as well. And so I think in the next decade, we're going to learn how do we manipulate our gut microbiome to improve our cancer treatments as well. There was a paper, probably about 6 months ago, and it looked at one of these immune therapy drugs called Keytruda. If you watch TV, you've seen Keytruda on TV. And what they found is if people had a certain bacteria called Akkermansia in their gut, they responded remarkably well to Keytruda. But if they didn't have that bacteria in their gut, there was no response at all. So there's this interplay, not with just our own cells, but with these cells in our microbiome that highly influences whether we respond or don't respond to treatment. So that's another frontier that we're just beginning to explore.
All right, and just before we wrap up the show and wrap up with the doc, and I got to mention again, this comes from USA Today. This is an excellent compilation they put together, so they deserve credit for this. Access and empowerment. Again, this is something that we have talked about. It's something to have access to the system and then have this sense of empowerment, and not this feeling of impoverishment that prevents some people from getting the care that they need.
Yeah. This is the societal issue for the next decade. And that is, how do we care for people who don't look like you and I, George? You know what? We are privileged, white, heterosexual males. And we don't understand what goes on with people. And I just think that if we're going to do a moonshot, then that moonshot has to include economic and societal equity within our entire society. So the example was Black women. Black women have higher incidence of breast cancer, and they die more frequently from breast cancer. Now, somebody say, well, they're genetically different. Baloney, they're not genetically different. It's an environmental, it's a societal problem. It's an environmental problem in that they live in areas that don't have access to appropriate food, shelter, housing, education, all of those things. And they also don't have as good access to the healthcare system. So they're not getting their mammograms, they're not getting their preventative care, and we're diagnosing them later. So it's a perfect example of a societal problem that more chemotherapy, better drugs is not going to cure.
And again, it's something that I talk about all the time on the podcast in different areas when we're talking politics in particular. But the way I put it to people, and it applies here, Doc, there's always this talk about pulling yourself up by your bootstraps and improving your own circumstances. But I tell folks that if you grew up on a cul-de-sac, instead of growing up in a shotgun shack, you don't have any understanding of what that's like.
Well, and you know what?
George,
I mean, that's a silly, silly argument in our society. The tables are stacked against people who aren't white. That's just, there's an inequity in all of our systems. There's an inequity in our food system. There's an inequity in our education system. There's inequity in our financial system. There's inequity in our healthcare system. These are systemic, institutional inequities that have been around since our African-American brothers and sisters were slaves. And until we get rid of those inequities, until we change the institutions that keep these people oppressed, you're not going to change healthcare.
That's and we're talking healthcare, but I mean, that's a great analysis of the world that we live in.
So that's my bottom line on that.
I think
I'm sorry if I offend people. But if you read the history of what's gone on in this country and you understand how we have institutional embedded inequity, then you'll understand why we aren't going to move this needle until we move those needles.
That's great. Well, I've run through my slides. That's great. I mean, he's singing my song. I mean, I just love this show, and I really love having Dr. Andrew Nish on.
Been here an hour, and I've got to get to another meeting.
Yeah, well, that's great. So, anything to close here? Or you just want us to wrap it up?
You know what? I don't know, George. I think I just closed with what I wanted to close with. I did have something. Hang on.
Okay.
Here we go. This is a quote. This is a quote from Sam Harris, and Sam Harris is a meditation master. He's a neuroscientist and all around kind of cool guy. And I want people to think about this. Everyone you have ever met, any person you will see out in the world today, friend, stranger, everyone is bound to lose all that they love in this world. We share this common circumstance. Nothing can last, and yet it falls to us to make this dream as beautiful as possible. Why would we want to be anything other than kind while it lasts? So we have hatred, we have vitriol, and you know what? Everything in this world is impermanent. We are all impermanent. We are all going to die. We don't know when we're going to die. So why would you not make every day as nice as possible and be as kind as possible to every human being? That's what it's saying. So I'm going to leave you with that.
Oh, that's great. I'll send you on your way with that. Doc, that's great. As always, thanks for coming on the podcast by George Liveline.
Thanks, George. Bye-bye.
Yeah, folks, I mean, that almost makes me weepy here at the end of the show. I'm telling you. There he goes. That's great. Folks, if you like having Dr. Andrew Nish in your living room, on your phone, in your car, wherever you might be catching this podcast, please subscribe to Podcast by George. Like us on Facebook. Follow us there. That's where this live stream was today. Go to YouTube and subscribe to us. We're on iTunes. We're on the iHeartRadio app. We're on Spotify. A lot of places, most of the places actually, where podcasts are seen or heard. But that's going to do it. That's going to wrap it up. That's all there is, and there ain't no more for this podcast by George Liveline. Thanks for watching.